Hello, and welcome to The Explainer. Today, we are diving deep into Echinococcosis, which you might also know as Hydatidosis. This isn't just any parasitic disease, it's a major zoonosis where tapeworm larvae create these slow-growing, tumor-like cysts inside the human body. As you can imagine, that makes it an incredibly formidable challenge, both for diagnosis and for clinical treatment.
So here's our roadmap. We're going to start with the disease itself and how it shows up. Then we'll get into how we actually identify the parasite. After that, we'll cover the treatment options, the potential complications and risks, and we'll wrap up with a look at prevention from a public health perspective.
All right, let's start with Section 1, the disease and its manifestations. You know, the really defining feature of echinococcosis is just how stealthy it is. It's a silent threat that grows incredibly slowly. We're talking about an incubation period that can stretch on for years, sometimes even decades, before a single symptom appears. So picture this. A 45-year-old shepherd, living in an area where this is common, comes in complaining about some vague discomfort in his upper right abdomen that he's had for a while. That's a textbook, but very nonspecific way this can start.
Now, from a clinical standpoint, we're really dealing with two different beasts here. First, there's cystic echinococcosis, or CE. This is from the parasite Echinococcus granulosus, and it's the one that forms those slow-growing fluid-filled cysts. But then you have alveolar echinococcosis, or AE. This one's caused by E. multilocularis, and it is much, much more aggressive. It actually behaves a lot like a malignant tumor, invading surrounding tissues, and it can be deadly if you don't treat it.
So where do these cysts end up? Well, for cystic echinococcosis, the most common form, the liver is ground zero in about 65% of cases. And this makes perfect sense when you think about the parasite's journey. After someone ingests the eggs, the little embryos, or oncospheres, burrow through the intestinal wall and get swept into the portal vein. The liver is the first big filter they hit. If they manage to slip past the liver, they get into the general circulation, and the lungs are the next most common stop.
The symptoms a person feels are completely dependent on where that cyst is and how big it's gotten. A cyst in the liver, like with our shepherd example, might cause abdominal pain or even signs of portal hypertension. If it's in the lungs, a patient might experience chest pain or cough up blood. If it makes its way to bone, you can see pathological fractures, and in the central nervous system, it can trigger seizures. One more thing, while you often think of eosinophilia, high levels of a certain white blood cell with parasites, it only shows up in about a quarter of patients, so it's not a reliable marker on its own. Okay, moving into Section 2, identification and causative agents. Because this thing is so quiet for so long, actually diagnosing it can be a real puzzle. The most obvious approach, looking at the cyst fluid under a microscope, seems like it should work, right? But it often fails. You're looking for the telltale signs of the parasite, the little protoscolosis and hooks, but they might not even be there. You see, the cyst could be sterile, or the host's own immune system might have already destroyed those key elements, especially in older, calcified cysts. This leaves you with a sample that tells you nothing.
Because of that, you absolutely have to take a multimodal approach. It's a three-step process. First, you start with the patient's history and a physical exam. Then comes the really critical part, imaging. Ultrasound, CT, and MRI are the workhorses here. They let us see the cyst and even classify it. And finally, you back that up with serology, looking for specific antibodies in the blood to confirm it's a parasitic infection.
To really understand this disease, you've got to understand the life cycles. For E. granulosus, the cycle runs between dogs and livestock, like sheep. For E. multilocularis, it's between foxes and small rodents. In both cases, humans are what we call accidental intermediate hosts. We get infected by swallowing the eggs from the animal feces, which basically puts a stop to the parasite's natural life cycle.
And here is a crucial point that can't be overstated. Because we're dealing with a helminth, a type of worm, and not a bacterium, standard antimicrobial susceptibility testing is completely irrelevant. This is a complex multicellular organism. We're not fighting it with standard antibiotics. We're using very specific antiparasitic drugs that target its unique biology.
And that brings us right to Section 3, therapeutic interventions. Let me be clear, there is no one-size-fits-all cure here. The strategy has to be multifaceted and totally individualized, based on the specific patient and their cysts.
We've got three main weapons in our arsenal: Surgery is still the go-to for cysts in really tricky spots, like the eyes or spine, or for any cyst that's causing problems just due to its size. Then there's a less invasive option called the PAIR procedure. That stands for puncture, aspiration, injection, and reaspiration. You basically drain the cyst and inject a substance to kill the parasite. Finally, there's the medical treatment, which relies on drugs called benzimidazoles, mainly albendazole. This is either used on its own or, more commonly, alongside surgery or paired to prevent any recurrence.
Now, what about kids? Symptomatic cysts absolutely can show up in young children. But here's the problem. There aren't specific, detailed guidelines for pediatric treatment. So for the most part, doctors have to extrapolate from what we know about adults. This means it's absolutely vital to bring in a pediatric infectious disease specialist to figure out the right approach and, of course, the correct dosing based on weight. So far, we've talked about what the disease is and how to treat it. But now we need to talk about what happens if it's missed or left untreated. Welcome to Section 4, Complications and Clinical Risks. Perhaps the most feared complication is the rupture of a cyst. Think about it. The fluid inside is teeming with thousands of tiny, viable protoscolosis. If that cyst bursts, all of that parasitic material can spill into the abdominal or chest cavity. This leads to what we call seeding, or secondary echinococcosis. It's a single event that can turn a contained, localized problem into a widespread, multi-organ disaster. It's a powerful and terrifying parallel to the way a cancer metastasizes. When you look at the numbers, you might see a mortality rate for cystic echinococcosis of about 2 to 4%. But that number is dangerously misleading. In a patient who is symptomatic and isn't treated, or in cases of that aggressive alveolar form, which has a mortality rate near 90% without intervention, the outlook is obviously much, much worse.
So the complications really run the gamut. You've got the simple mechanical pressure of a growing cyst squishing nearby organs. You have the risk of life-threatening anaphylactic shock if a cyst ruptures. You can get secondary bacterial infections, and then you have those two big ones, the widespread seeding of new cysts and the relentless invasive growth you see with the alveolar form.
And all of this really underscores the critical importance of prevention. Which brings us to our final section. How do we break the chain of transmission? For both types of this parasite, transmission happens through the mouth by ingesting microscopic eggs from a contaminated source. For E. granulosus, that source is usually dog feces that has contaminated soil, water, or even food. For E. multilocularis, it's usually fox feces. And here's the key takeaway for public health. You cannot catch this disease directly from another infected person. Prevention, then, really has to target the entire cycle: humans, animals, and the environment. It comes down to 3 core things. First, just strict personal hygiene. Second, managing and regularly deworming the animal hosts, especially domestic dogs. And third, trying to control where livestock graze to keep them away from contaminated areas.
So, to sum it all up, Echinococcosis is a really complex parasitic disease. It's defined by its stealthy, slow growth. Diagnosing it requires a smart combination of imaging and blood tests. And treating it means creating a custom plan that might involve drugs, procedures, or both. But the real key is understanding and interrupting its fascinatingly complex life cycle.
And now for a brief moment of, shall we say, parasitological humor before our final thought. Why did the Echinococcus cyst break up with the liver? It said, "You're too toxic for me and I need space to grow."
But that brings us to a final and much more serious question. The life cycle of this parasite ties together wildlife, our domestic animals, and our own health in this intricate web. So we have to ask ourselves, are the hygiene and control measures we have in place right now actually strong enough to truly break that chain? It's something we really need to think about.